Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea, Dean of the School of Public Health at Washington University in St. Louis, and also Editor-in-Chief of JAMA Health Forum. Today we discuss the implications of the 2022 Dobbs v. Jackson Women's Health Organization decision, which overturned Roe v. Wade and fundamentally changed the reproductive health landscape in the U.S. In the wake of Dobbs, regulatory power returned to the states, and by the end of 2022, more than a dozen states had implemented near-total abortion bans. The result is a patchwork of laws ranging from complete bans to robustly protected access. This dramatic shift has raised wide-ranging concerns about women's health. Many of the states enforcing strict bans are in regions that already face poorer health outcomes, and there are fears of exacerbated disparities for low-income and minority communities. Observers have warned of potential rises in maternal complications and even deaths if pregnant people cannot obtain needed care. There are also worries about increases in unsafe abortion attempts if access to clinic-based care is blocked. In short, the post-Dobbs era represents a pivotal moment for reproductive health policy, one that could have profound effects on women, children, families, and the health system at large. Addressing these challenges and understanding their impact has never been more important. Here to discuss what has happened since Dobbs and what might lie ahead is Dr. Diana Green Foster of the University of California, San Francisco. Dr. Foster is a professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF and a demographer with advancing new standards in reproductive health. She led the landmark Turnaway Study, a nationwide longitudinal project that examined the outcomes of nearly 1,000 women who received or were denied abortions, providing key insights into how unwanted pregnancy affects health and well-being. Dr. Foster's research has been instrumental in informing policy discussions on family planning and abortion access. She has been widely recognized for her contributions to reproductive health research, including being named a 2023 MacArthur Fellow. Dr. Foster, thank you for joining.
Thank you, Dr. Galea.
So it's been over 3 years since Dobbs' decision overturned Roe. So from your perspective, how has the landscape of abortion access in the U.S. changed during this time? What are the most significant shifts in abortion provision and access that you've seen?
There has been a radical change in abortion provision in the country, a substantial impact on both the number of providers and people's travel, not just because of the Dobbs decision, but one thing that happened at the same time was because of the COVID pandemic, the FDA, the Food and Drug Administration, allowed the medication abortion pills, mifepristone and misoprostol, to be provided via telehealth. So the combination of the Dobbs decision, which a third of states imposed bans, and the FDA allowing telehealth has meant that everything has changed in abortion care. All of a sudden, some people are traveling hundreds of miles to get abortions across state lines, and other people are ordering pills sent to their doorstep. So it has been a huge change. And I think in addition, the anger about the Dobbs decision made a lot of people donate to abortion funds. And so all of that travel across state lines has been aided by what I call rage donations of people who are angry about the decision, gave to a local abortion helpline or fund, which has helped people pay for that travel. Some people are getting abortions who couldn't have gotten abortions before. And some people are likely unable to access abortion.
Let's talk a little bit about what's happening on the ground to people. I feel like sometimes these conversations get abstract. So if you have a woman with relatively few assets available to her in a state with a total or near total restriction of abortion access, what's happening?
Everything depends on whether she has information or not. If she doesn't, there are some websites like plancypills.org, ineedana.com, which will lay out all of her options, which include having pills sent to her sometimes for free and sometimes for a nominal $5, sometimes for $50, but she can have pills sent to her. That doesn't work for everyone. If you don't have a computer, you're not going onto these websites. And if you don't have $5 to $50 or a credit card, you're also not able to pay. So that solution doesn't work for everybody. But if she is able to get in touch with an abortion fund, there are funds that will cover her travel and help her find a provider. And that system existed before Dobbs, but has become so much more robust since Dobbs, which is really ironic that abortion access would improve in response to the Supreme Court allowing states to ban abortion.
Let's talk about what this means for health outcomes themselves. So there were initial warnings that reducing access to abortion could lead to more adverse maternal health outcomes. So we're now 3 years out. What do we know about maternal health in states with abortion bans? Are there signs of increased pregnancy-related complications or even maternal mortality emerging in the data?
Interestingly, there was a sharp decrease in maternal deaths after Dobbs, but not due to Dobbs, because Dobbs was decided in June 2022, and the year before, 2021, had a massive increase in maternal deaths due to COVID. So if you weren't careful, you could look and say, oh, look, Dobbs lowered maternal deaths, and that is not the case. And to further complications, states that have imposed abortion bans had massive problems with maternal mortality and a lack of sufficient maternal health care providers before Dobbs, a historical problem with obstetric provision and abortion provision. So, the decrease in maternal mortality that we've seen nationally since Dobbs has been greater in the states that have protected access than states that have abortion bans. But how much of that improvement is due to the lack of improvement in states with bans is due to people carrying unwanted pregnancies to term, we don't really know yet. What is clear from the medical literature is that carrying a pregnancy to term is much higher risk than getting an abortion. So if people can't get abortions, we expect maternal mortality to rise. And especially if the people who can't get abortions are disproportionately people who have pre-existing health conditions and are in places with maternity care deserts.
So what about outcomes for infants and children? There was a recent paper from Texas showing a rise, about 2.3%, in infant mortality after stricter abortion laws. So what do we learn from these early signals?
The topic of abortion bans and infant health is really interesting and not intuitive. But here's what the connection is that sometimes people end pregnancies because they're given a fetal diagnosis that the baby, if born, won't survive for a long time, that the infant has a condition that is incompatible with life. And so many people in that circumstance choose to terminate the pregnancy rather than carry a pregnancy to term and have their child die after birth. So when abortion is banned, more people carry pregnancies to term that have fetal diagnoses. And that's what Alison Gemmell and colleagues at Johns Hopkins found in Texas, was that when Senate Bill 8 passed in Texas, banning abortion in early pregnancy, people carried pregnancies to term who had received fetal diagnoses. They were unable to end those pregnancies, and they gave birth to infants with congenital diagnoses who died after birth. What we've seen nationally since Dobbs is similar. So Singh and Gallo from Ohio looked at national data and found a 7% increase in infant mortality overall, most of which was due to infants with congenital anomalies. So this is certainly not what people think is going to happen when they impose a abortion ban. But I think a lot of the people who impose abortion bans don't understand the context of abortion and why somebody would have it. And sometimes it's because their child has conditions that aren't compatible with life.
Let's talk about the Turnaway study, which you've conducted for some time. And before Dobbs, you showed the long-term consequences when women were denied abortions, including higher rates of serious pregnancy complications, worse mental health, greater financial hardship, and higher odds that children born live in poverty. So in the post-Dobbs era, as more women are forced to carry unintended pregnancies to term, are we seeing indications of similar challenges? What do you think the Turnaway study teaches us about what we should be looking for in the short and medium term about women's health going forward?
Yeah, so I led the Turnaway study, which really revealed what happens when people can't get wanted abortions. It also was done before this Dobbs decision. It was done when Roe was the law of the land. And so people who think, oh, we should return to Roe should know that when Roe was the law of the land, many people couldn't get wanted abortions. This isn't a new problem in the United States. We've had difficulty with access to abortion for a long time. And what we found in the Turnaway study was that people who can't get abortions are more likely to end up below the federal poverty level, more likely to not be able to achieve aspirational plans for themselves. They have poorer physical health. their children do worse in terms of development and living in economic security. And the extent to which that's again happening post-Dobbs is not totally known yet. What we know is that some people are better able to get their abortions now because prices have gone down for ordering pills online, and there are funds set up to help people travel to clinics. So many people are able to get abortions, but the fraction of people, which might be around 3 to 5%, who want an abortion who can't get one, are probably disproportionately the most vulnerable, meaning they are ones who didn't get the information about ordering pills online, or they can't travel because they're too sick. So people who already have poor health are probably less able to get an abortion and will have worse outcomes. I'm doing a study right now of people in emergency departments who show up with pregnancy complications. If you're in the middle of preeclampsia and you're having seizures, you're not going to travel across state lines, and you may not get the care that you want. You may not be able to get rapid, good care from an emergency department in a state with a ban. So it's people who don't have access to information or resources to travel, and people who are too sick or incarcerated or institutionalized. Those folks can't cross state lines and probably won't be able to circumvent their state law.
So let me shift to the impact on clinicians and the healthcare workforce. So we've heard warnings that limiting abortion access may reduce training opportunities for obstetrician gynecologists. And we've actually seen some reports of abortion providers relocating from restrictive states to states where they can practice freely. So how is Dobbs affecting medical training, distribution of providers, and what do you think these trends mean as we go forward?
This is an area that is of huge concern because states that have passed abortion bans are already maternity care deserts. So lower numbers of OBGYNs per women of reproductive age in banned states, the highest maternal mortality in these states. So anything that reduces either the number of providers or the training they receive is very serious. And what we've just started to see is small declines in the number of OBGYNs. Looking at the National Plan and Provider Enumeration System, this is data analyzed by colleagues at the Oregon Health Sciences University, starting to see a small decrease in the number of OBGYNs. And there have been other documentation of fewer applicants for medical students and residencies in banned states, but not decreases in people filling those positions. So it's not a huge effect yet, but numbers are not all of it. The question is, when you end up as a medical student or a resident in a state with a ban, are you going to get the training that you need? So something like 40% of OBGYNs residents just lost access to training. And there's something called the Ryan Residency Program that is run out of my university, University of California, San Francisco. And they're trying to have OBGYN residency programs in states with bans be linked to residency programs in states without bans so that residents can get training in evacuating a uterus. And that is critical skills to have. It's part of accreditation to be an OBGYN is you have to be able to do that. It comes up outside of the context of abortion for miscarriage management. It also comes up when people have emergencies and their health is at risk or life is at risk even if they don't get that service. So people need that training, and these bans make it so that there's thousands of residents who are not easily able to get the training that they need, and medical students and nursing students as well. So this is something that really needs attention because already care was poor in these states before this ban.
You spoke earlier about mail order medication abortion, but let's talk a little bit about telehealth for a second, because we know that telehealth can provide opportunities for access in places where there's less access. What do we know about telehealth in this context? Is there a paradigm shift going on around telehealth, around abortion care?
Yeah, it has been absolutely massive, the growth in telehealth. So what telehealth involves is being screened by a medical provider for medication abortion, either via text messaging or video conference. And there's been a dramatic increase since Dobbs. My colleague Ushma Upadhyay at UCSF did an analysis of safety and effectiveness and found that less than 0.25% of telehealth patients experienced a serious abortion-related adverse event, and that is very similar to FDA estimates for in-clinic provision. And that sort of makes sense because if you're receiving pills, whether you travel to a clinic to be handed them or have them mailed to your house, the physical experience of taking them is similar. People know whether they are contraindicated for these pills. It's easy to screen yourself. It's easy to know whether you want an abortion or not. But the question is, do people get the information they need about what to expect with the procedure and where to get care after? And then the question is, are people afraid to get care if they need it after because they're scared of getting in trouble with the law? So that is a big concern, and it's something that we're studying in terms of emergency department care.
I'm going to come to the science in a second, but let me ask you one other question about service delivery. There have been fears, reasonably enough, that if safe abortions become harder to get, we might have an increase in use of unsafe methods. Have we seen an increase in unsafe or clandestine abortions or related complications since Dobbs?
This was one of my greatest fears with the Dobbs decision, and it has not panned out at all on the level that I expected. We know that even during Roe, when Roe was the law of the land, people tried dangerous things to end their pregnancies, things that aren't necessarily dangerous but are ineffective and therefore postpone their seeking care. Both of those are a problem. My colleague Lauren Ralph at UCSF looked at ever attempted to induce your own abortion without help from the medical system and found an increase just between the years 2021 and 2023, increase in having attempted SMA. Mostly people try herbs, but also physical methods like hitting themselves in the abdomen, trying to use large quantities of alcohol and other substances, and about 1 in 6 sought medical care for complications. But this is still very rare compared to getting your hands on medication abortion and having a safe abortion. So this has increased, but it is nowhere near the scale that I expected because I was thinking of the pre-Roe era when there weren't medication abortion pills and people went to untrained providers and got unsafe procedures. We are not primarily in that era, which is, I think, thanks to medication abortion pills and these funds that are helping people travel to safe clinical care.
Now, let's shift to research for a second as a scientist. So how are you approaching studying the changing post-Dobbs reality? What are the biggest challenges in gathering data? I keep thinking about gaps in public data, like, for example, limitations in the official abortion surveillance systems. How are you and the rest of your colleagues who study this area centrally adapting and making sure that you continue measuring and understanding the impacts on health and healthcare?
Yeah, there is more research interest than ever in abortion. As you pointed out, there's no complete abortion surveillance in this country. And even more so, it's a problem when more people are doing this outside of the law. So 2 nonprofit groups, one at Guttmacher and one at the Society of Family Planning, are estimating abortions provided through clinics and through telehealth. But there's this huge group of people who we don't even know how large it is, who are ordering pills outside of the medical system, not telehealth, just websites that sell pills. And we really don't have a sense of how large that number is. So we don't have certainty in the number of abortions that are happening, but the ones that we can count show an increase over what happened before Roe. So the big concerns now when abortion is illegal in some states about studying it is about data security and also about funding. I have a research grant through the NIH to study the effect of the Dobbs decision on access to abortion, and it was briefly canceled 6 months between March and September of last year. It was canceled, but not because of abortion. It was canceled because in my introduction, I mentioned that 36 million women and an unknown number of trans people are affected by abortion bans, and the grant was canceled for being about trans people. So it wasn't canceled for being about abortion, but for bans on trans research, which is just absolutely crazy. And eventually a lawsuit got it back for me. So I'm continuing that work. While there are challenges, one thing that has changed is that people are so willing to participate in research because they know it's important. So I have a study of what happens to people in emergency departments, and I'm interviewing and surveying emergency department physicians, both emergency medicine physicians and OBGYNs who consult in emergency departments. And you can imagine wanting to study emergency department physicians, like that seems like an incredibly important group of people to get and very difficult to get. They have no time and they're busy, and who's going to participate in research at this point when you've got emergencies going on? So I promised, to the funder, I would get between 100 and 200. And what happened is I opened this survey and we had 400 people in the first week agreeing to participate. We sent it out through professional networks and were overwhelmed, ran out of gift cards because there was so much interest in responding to this survey, which was documenting what their practices are and how they've changed since the Dobbs decision. We were overwhelmed by participants. That has never happened in my entire history of being a researcher, to be overwhelmed with respondents. But if you think about the experience of being an emergency department physician, all of a sudden state laws are changing the way you practice, creating uncertainty about whether you can provide what you think is the standard of care. You want to tell someone about it. You want to be able to share, what you do in the case of someone with an ectopic pregnancy, what you do when somebody has premature rupture of membranes, and how that may have changed. And so, the upside of things being uncertain is that folks have wanted to participate in research at a higher level, which is another unexpected effect of the Dobbs decision.
You're almost anticipating my last question about the positive, but we'll get to that in a second as well. Understanding the complexities of the moment and understanding the Dobbs decision and the current political reality, are there policy measures that you think would be helpful right now to protect and improve reproductive health? What should policymakers, both at the state and federal level, be focusing on at the moment?
Here's the real risk, in my opinion, is threats to Medicaid funding, threats to abortion provision have had the effect of closing family planning clinics, which means lower access to contraception, a loss of people who have expertise on miscarriage and pregnancy loss. Any threats to Title X funding reduce reproductive health services. And the United States has been lagging in pregnancy, prenatal care, delivery services compared to other industrialized countries. We have one of the worst maternal morbidity rates, and it's particularly a problem in the states with bans. So we need greater security of the family planning healthcare system generally, and a dramatic investment in maternity care. I think that these abortion bans were passed with the expectation that people would carry unwanted pregnancies to term, with no investment into the healthcare that they would need if they were to do so. So I know there's concern nationally about low fertility rates. If we want higher fertility rates, we need abortion to be legal and accessible because it's a natural part of pregnancy planning and dealing with pregnancy emergencies, even for wanted pregnancies. And we need so much more investment in family planning services and maternity care. One can't just increase fertility rates by banning abortion. To do this ethically, to try and support people who want to have kids, there needs to be a huge investment in public health and medical care around pregnancy.
Let me ask perhaps the hardest question, because this is a prognostication looking ahead. I mean, you've already said several times things in the past 3 years were not exactly what we thought was going to happen in the past 3 years. So let me ask you to look forward 3 years, 10 years. Where is the post-Dobbs story headed?
I feel like the future depends on politics rather than evidence. The evidence is completely clear and doable, feasible. Our country could do it, about how to improve health and well-being. And it's about providing healthcare and letting people make their own decisions. The current government has shown a lack of respect for science and a lack of respect for evidence, and the sense of responsibility for people's health and well-being isn't there. So it's up to civil society to make up for gaps in what we used to be able to count on in terms of public investments. Civil society has stepped up in many ways. We have, these rage donations to abortion hotlines is a small part of it, but people care about motherhood and children, and we can do so much better than we are doing. And maybe this period of lack of respect for motherhood will, I hope for a rebound where we change direction and recognize that disregarding the important care that happens during pregnancy and after is just vital to our country's well-being.
You've already surprised me a couple of times by sprinkling in the positive in this conversation, so let me end on the positive. So it's been a challenging period. I can only imagine how challenging it's been for you studying this throughout your whole life. Are there developments in policy, healthcare delivery, public awareness that make you optimistic about the future of reproductive health in this country?
When I led the Turnaway study, one thing that was clear was that when people are trying to make decisions about pregnancy, they know their own situation, they know their own capacity to care for another child, and they make decisions that are right for themselves. So what this post-Dobbs period has shown is how determined people are to live out their own decisions, to not let state legislators make decisions about their childbearing for them. And so we've seen people go around state laws by traveling or by ordering pills online. What gives me hope is people's determination and resilience. I'm a very optimistic person generally, and I just think that this period is dark and that we will come around, because this isn't sustainable to be so anti-woman and anti-childbearing as we currently are, and that the outrage that has fueled abortion hotlines and that has gotten the word out about medication abortion, that energy can also go towards making more evidence-based policy when we have a better administration.
I'm Sandro Galea. I have been speaking with Dr. Diana Green-Foster about the post-Dobbs era and its implications for reproductive health. Thank you, Dr. Foster, for talking to us, for the work you do.
Thank you, Dr. Galea. It's really great to be on your podcast.
Follow us on JAMA Health Forum and the JAMA Network for more conversations on health policy. This episode was produced by Daniel Musisi at the JAMA Network. To listen to this and other JAMA Network podcasts, visit us at jamanetworkaudio.com and jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.